association with dyslipidemia. Meibomian gland dysfunction is one of the most under-recognized, under-appreciated, under-treated disease in ophthalmic practice.
Watch is not started yet. Not yet started timings.
It has already started.
Okay.
It is a chronic diffuse abnormality of the Meibomian glands, commonly characterized by terminal duct obstruction with qualitative or quantitative changes in glandular secretion. It may result in alteration of the tear film, symptoms of eye irritation, and clinically apparent inflammation and ocular surface diseases. Recent studies have shown that the prevalence of MGD in general population varies between 30.5 and 54.1%. Aim is to study the association between Meibomian gland dysfunction and dyslipidemia. An objective is to understand the relation between Meibomian gland dysfunction and dyslipidemia. Materials and methods. It is a prospective observational study in RIO RIMS Ranchi for a duration of 18 months. 60 patients who were diagnosed with MGD were included in the study. Informed consent was obtained prior to enrollment in the study. Then Meibomian gland status was evaluated according to International Workshop on Meibomian Gland Dysfunction and Management 2011. According to this, MGD is divided into 4 stages. Stage 1, no symptoms of ocular discomfort, itching or photophobia, with minimally altered secretions, and expressibility which was assessed from 5 glands of the central third of the lower eyelid, and in stage 1, 3 to 4 glands are expressible. Stage 2, minimal to mild symptoms of ocular discomfort, scattered teeth margin features, mildly altered secretions, and 3 to 4 glands expressible. Stage 3, moderate symptoms of ocular discomfort, increased teeth margin features such as plugging and vascularity, moderately altered secretions with 1 to 2 glands expressible. Stage 4, marked symptoms of ocular discomfort, increased teeth margin features such as dropout and displacement, severely altered secretions and no glands expressible. Lipid profile was done from an overnight fasting sample and evaluated for total cholesterol, high density lipoprotein, low density lipoprotein, and triglycerides. Results. Out of the total 60 patients, 28 were male, which is 46.67%, and 32 were female, which is 53.3%. And as far as age is concerned, the number of patients who are less than 30 years of age are maximum, which is 30%, and the number of patients with age more than 50 years are minimum, which is 18.3%. Total cholesterol and stages of MGD. The number of patients with total cholesterol less than 200 is 43, which is 71.67%, and number of patients with total cholesterol more than 200 is 17, which is 28.3%, and the maximum number of patients with total cholesterol less than 200 belongs to stage 1 of MGD, while maximum number of patients with total cholesterol more than 200 belong to stage 4 of MGD. The other parameters of lipid profile, such as LDL, HDL, and triglyceride, also follows the same trend, in which the number of patients who have a normal lipid profile are more in number, and in those patients, most of them have stage 1 or stage 2 MGD, whereas the number of, in those patients who have abnormal lipid profile, they have either maximum number have stage 3 or stage 4 MGD. Conclusion. A positive association exists between increasing severity of MGD, increasing level of all the components of lipid profile, such as LDL, HDL, total cholesterol, and triglyceride. These findings suggest that MGD diagnosis may go for a dyslipidemia screening. However, the type of plasma lipids associated with MGD has varied among studies and has not been clearly identified which plasma lipid abnormality is responsible for MGD. A larger study with more sample size and more duration will help validate these findings. MGD may become a marker of previously unknown hypercholesterolemia, and ophthalmologists may increase their role in early detection of an important risk factors of cardiovascular diseases. These are my references. Thank you.
Why is your study number is so small, only 60?
Yes, sir.
You are done for 18 months duration, no?
Yes, sir. Actually, it was supposed to be more than that, but The number of people who came back with their lipid profile done.
So you mean HDL is also increased as the stages?
Decrease, sorry.
You mentioned more than 40 HDL. HDL.
Less than 40.
Less than 40 in
Yes,
which stage?
Stage 3.
3.
Yes, sir.
And after that,
And after that,
in first
maximum-
and second stage, it is less than 40.
yes.
Please show that slide again, please.
In HDL,
More than 40
yes.
and less than 40. So, more than 40 maximum number belongs to stage 3.
Yes.
More than 40.
No, sir, less than 40.
HDL, okay.
Less than 40.
So it is depending on the upper state.
Yes, sir.
Hmm.
So how do you assess MGD? What are the tests you are
Yes,
doing?
sir. Sir,
You are doing mammography.
by checking the opening of the mebumin gland, and then expressibility is checked by pressing at the level of the tarsal gland. Normally, if the function is normal, the secretion will be clear fluid, whereas in MGD, the secretions will become thick and milky and toothpaste-like. Thank you, sir.
Thank you. Thank you.
Second speaker, Dr. Jitendra. Is he here? Dr. Jitendra? Not present. Dr. Simran Dhawale. Comparative study between dexamethasone versus normal saline in sutureless pterygium graft dissection. Yes, please. Yeah.
Hello. Good afternoon, respected chairpersons. Myself, Dr. Simran Dhavre. I would like to present a comparative study of dexamethasone versus normal saline in sutureless pterygium graft dissection. Pterygium, as we all know, is an elastic degeneration of the subconjunctival tissue that affects the exposed bulbar conjunctiva. Prevalence in Asia is said to be around 10.2%. If left untreated, it may lead to corneal scarring, chronic ocular surface inflammation, irregular astigmatism, and restriction of the ocular movements. Subconjunctival administration of dexamethasone at the time of surgery provides a targeted approach, delivering high local concentrations with minimal systemic absorption. Our aim in this study was to evaluate the effect of administration of subconjunctival dexamethasone versus normal saline during conjunctival autograft harvesting in pterygium surgery. Our study was a single-blind randomized control trial conducted in the Department of Ophthalmology for a duration of 12 months. Our sample size was 50. It was divided into two groups, 25 each. Patients presenting with primary pterygium were included in our study. The exclusion criteria are stated here. Institutional ethical clearance was obtained. A pre-designed performer was used to record the patient details. Complete ocular examination was conducted of the patients. All patients underwent sutureless pterygium excision with conjunctival autografting. During the autograft harvesting, group A individuals were injected with 0.5 ml of injection dexamethasone, whereas group B individuals were injected with 0.5 ml of normal saline. Post-operative assessments were done on post-operative day 1, 7 and 21 on the basis of pain, lid edema and conjunctival inflammation. This is the universal pain scale assessment tool. The lid edema was graded according to the width of the palpebral aperture. The grading of the conjunctival inflammation was according to the degree of the blood vessels injection. Moving on to the results. In age-wise distribution, most of the patients presented with 40 to 60 years of age. In gender-wise distribution, almost equal number of genders were present in both the groups. Most of the patients presented with grade 2 pterygium. On the basis of inflammation, for post-operative day 1, 9 patients presented with mild grade of inflammation, whereas in the NS group, they presented with moderate to severe grade of inflammation, which was statistically significant. On post-operative day 7, 15 individuals out of 25 presented with no inflammation, whereas in the NS group, they presented with mild to moderate grade of inflammation, which was significant. On the basis of lid edema, on post-operative day 1, 18 patients presented with mild grade of lid edema, whereas 17 patients presented with moderate grade of lid edema. On post-operative day 7 and post-operative day 21, the lid edema subsided. On the basis of pain, on post-operative day 1, in the DEXA group, patients presented with mild to moderate grade of pain, whereas in the NS group, they presented with moderate to severe grade of pain, which was significant. On post-operative day 7, 15 patients presented with no pain, whereas in the NS group, 17 patients presented with mild grade of pain. By day 21, almost all the patients presented with no pain. Our study shows that dexamethasone significantly reduces post-operative inflammation and pain, especially in the early post-operative day. Though over time, these differences diminish, and by day 21, most of the patients in our group have minimal or no symptoms. Our results are consistent with the prior studies examining the effect of subconjunctival dexamethasone. This is a comparison between our study and the prior studies. Due to the small sample size, which is 25 in each group, it limits the generalization. To conclude, subconjunctival dexamethasone during conjunctival autograft harvesting significantly reduces immediate postoperative discomfort, thereby improving patient compliance and satisfaction. Following are my references. Thank you.
So for harvesting, you are using dexamethasone, giving injection?
Yes, sir.
Anyway, post-operatively, you are giving dexamethasone?
No, sir. Only while harvesting.
Only for harvesting?
Yes, sir.
Post-operative
No,
medication?
sir. No.
You are not using
No,
any steroid?
no, sir.
Okay, so your study suggests
Dexamethasone.
so all three parameters are just depends on inflammation only. How is the pain related to dexamethasone?
Pain comparatively is less as compared to what we have seen with the patients in NS, sir. In early postoperative day, by the time, yes, sir.
So it's only inflammation.
Inflammation. Sir, recurrence of pterygium. Sir, not as long as the study was there, like for 21 days, there was no pain. Yes, sir.
You are the first year resident?
No, sir, second year resident. Thank you, sir.
Dr. Nupur Gupta.
Good afternoon, dear judges and members of the House. Today I'll be presenting a study on the ocular surface microbiome in patients with breast cancer. We know that the ocular surface microbiome is paucibacterial and helps in maintaining the ocular surface homeostasis, and any derangement or dysbiosis leads to ocular surface disease. The study came about with the concept of that breast cancer therapies like chemotherapy and radiotherapy and hormone therapy do cause some amount of ocular surface symptoms and dry eye disease. So with the rationale of finding out the connection between ocular surface disease, meibomian gland dysfunction and the core ocular microbiome in these patients, we planned this study with the primary aim to characterize the ocular surface microbiome by metagenomics in these patients who were on systemic therapy, and the secondary aim was to find the ocular surface parameters like ocular surface disease index, the non-invasive breakup time, LLT, and tear meniscus height through the ocular surface analyzer. So, breast cancer patients undergoing various systemic therapies were recruited from the surgery department at All India Institute of Medical Sciences, New Delhi. So, conjunctival swabs were taken from the inferior conjunctival fornix, and DNA was isolated, and then a microbiome analysis was done by bioinformatics. The patients also underwent a comprehensive ophthalmic workup, including a dry eye workup. Coming on to the results, the age range of the patients was from 30 to 79 years, and most of them were under either hormone therapy or chemotherapy, and there was an equal distribution in these groups. On dry eye workup, we saw that it was surprising to note that all the patients had some form of meibomian gland dysfunction and had a deranged non-invasive breakup time. The lipid layer thickness was thin in all of these patients to a varying degree. And these were some objective evidence we got, and then all patients had a thin lipid layer and a reduced non-invasive breakup time. When we did a microbial analysis, the diversity analysis showed that patients on chemotherapy had a less diverse microbiome than a normal core microbiome, and they also had a decreased richness. So, this is the genera that was found in the three groups. NT is the treatment naive or no treatment group, HT is the hormone therapy, and CT is the chemotherapy group. We can see in the chemotherapy group we have an abundance of staph epidermidis, which likens to a core microbiome in patients with dry eye disease and meibomian gland dysfunction. However, the treatment naive did not have much prevalence of staph epidermidis. They had a virome which is near the core microbiome or a normal ocular surface microbiome. Even Klebsiella was found more in patients on chemotherapy. So to conclude, the ocular surface microbiome profiles in patients of breast cancer did show a core microbial community as that of patients with dry eye disease and meibomian gland dysfunction. It is a less diverse microbiome with increase in flora like staph epidermidis, and we see that all therapies for breast cancer impair the ocular surface. So the findings of this novel study suggest that there is a microbial shift, and there may be a role of microbiome targeted therapies to decrease the prevalence of dry eye and ocular surface side effects due to breast carcinoma therapies. Though this was a cross-sectional study, we recommend longitudinal cohorts pre and post-treatment sampling to determine causality and explore microbiome targeted therapies further. Thank you.
Any long-term studies going on?
Yes, sir.
Your studies?
So the samples are collected. This took 2.5 years.
And how soon we start seeing the symptoms of dry eye in these chemotherapy or whatever?
So around 6 months. So the range of the duration of the disease was from 6 months to 10 years in these patients. As early as 6 months, they had symptoms of dry eye disease, and also all of them had signs.
So you suggest after 6 months one should have
they should be referred to an
ocular
ophthalmologist, and proper therapy should be started.
Thank you.
Thank you, sir.
Next speaker, Dr. Smruti Gavalkar.
Where is my?
Good afternoon. I am Dr. Smriti Gavadkar, SVN GMC Yavatmal. Today I am presenting the paper on assessment of meibomian gland using an autorefractive keratometer in dry eye tissue. So meibomian gland dysfunction is a leading cause of evaporative dry eye disease. This makes a non-invasive mammography an important procedure in the clinical evaluation of dry eye patient. Our purpose was to conduct a lead-up innovation, focus on practicality of performing mammography using an autorefractive keratometer in developing country with limited access to complex imaging system. A total 353 patients presenting with dry eye disease symptoms were including meibomian gland morphology was examined with a slit lamp under examination and non-contact mammography using an autorefractive keratometer. Meibomian gland loss was quantified by Paul's grading scheme. Dry eye measure include tear breakup time, Schirmer test, correlation between meibomian gland loss, T-Bird test and Schirmer was analyzed. Maximum number of participants present in the age group of 51 to 60 years and minimum number of present in the age of 21 to 30 years. Gender wise distribution almost equal. 38.81 patients have a T-Bird test positive and 61.19 patients have T-Bird negative. 97.40% patients have meibomian gland loss was present and 2.55 patients have not having gland loss. Sensitivity of Schirmer test is 39.53 and specificity is 18.89. P-value with wide correction of mammography and Schirmer test is 0.1831. Thus, there is no significant difference between these two tests. Hence, both tests are highly associated with each other. Result was overall mean meibomian gland loss was 15.87% in female and 49.13% in the male, almost equal. P-value for mammography and T-Bird test was 0.4143 for mammography and Schirmer test was 0.1831, thus providing that there is no statistical difference between these two tests. Moderate correlation was found for mammography and T-Bird and mammography and Schirmer test. So we conclude that this study demonstrates that mammography has high specificity and sensitivity to diagnose meibomian gland dysfunction in dry eye patients. It also suggests that it is feasible, beneficial and cost effective to examine meibomian gland by using an autorefractive keratometer in developing country with limited access to complex imaging systems. Thank you.
Which autorefractive is
Appasamy.
use the mammography photo?
Taking photo on mobile. Okay. Yes, sir.
There are some autorefractors give a mammography.
Yeah.
Is it convenient to use this autorefractokeratometer seeing this meibomian gland? Because I have tried a number of times, it's not as convenient. It's really making.
Where the machines was in our institute, only autorefractive keratometer was present. So we use, but not in tertiary care or in some.
In basic setup, I want to know, because autorefractokeratometer is available in even basic these, and we have also tried. But although things are visible, but it's little inconvenient or little difficult to see the.
Yes, sir.
I hope with practice you may have mastered it. Anyway.
So your study says T-Bird and mammography are similar results.
Yes, sir.
So incidence of meibomian gland dysfunction is more in older age groups.
Yeah.
It is very.
Yes, sir.
But first speaker mentioned it little bit difficult. Okay.
Okay, thank you.
Next speaker, Dr. Leena Benjamin. So, next, Dr. Uzma Javed.
Good afternoon, respected chairperson and audience. Myself, Dr. Uzma Javed, and I'm going to present on comparative analysis of dry eye disease and corneal nerve sensitivity in diabetic and non-diabetic patients. Introduction. Dry eye disease is a multifactorial disorder of the tear film and ocular surface that leads to symptoms of discomfort, visual disturbance, and potential damage to the cornea and conjunctiva, and is often associated with reduced tear film stability and increased osmolarity. Diabetes is recognized as an important systemic risk factor for DED, with chronic hyperglycemia contributing to ocular surface inflammation, tear film instability, and corneal neuropathy. The objective of my study was to compare the prevalence and severity of dry eye disease and assess corneal nerve sensitivity in diabetic and non-diabetic, and to evaluate the association of dry eye severity with retinopathy and corneal nerve sensitivity. Materials and method. This was a hospital-based cross-sectional analytical study conducted in the Department of Ophthalmology, carried out over a period of 6 months, and a total of 20 patients were included in the study, comprising 10 diabetic and 10 non-diabetic, aged between 35 to 55 years. Inclusion criteria. Patients aged 35 to 55 years. Group 1, diagnosed cases of type 2 diabetes with or without diabetic retinopathy. Group 2, age and sex matched non-diabetic individuals without ocular surface disease. Exclusion criteria, patients with a history of ocular surgery, trauma or contact lens use, and patients on topical medications like pilocarpine, timolol, etc. Systemic conditions known to cause dry eye like rheumatoid arthritis, Sjogren's syndrome, and thyroid disease, and patients with active ocular infection or inflammation. Demographic and clinical data, age, gender, history of diabetes, duration, and HbA1c levels were recorded. An assessment of dry eye disease was done by a structured questionnaire for symptom evaluation. Schirmer's test to measure tear secretion and T-Butt to access tear film stability. Corneal sensitivity was performed using the Coque-Bonnet aesthesiometer. The longest filament length producing a positive response was recorded in millimeters. Diabetic retinopathy assessment, the fundus examination was done using indirect ophthalmoscopy and FFA, and retinopathy was graded according to the early treatment diabetic retinopathy study classification. Results and analysis. The baseline characteristics of study population was almost the same. Mean age was almost same among diabetic and non-diabetic, and gender, there were 6 males, 4 females in diabetic, and 5 each in non-diabetic. The mean hemoglobin A1c level was more, as we can see in the diabetic group, that is 7.9 plus minus 1, 2. Prevalence and severity of dry eye disease revealed that moderate to severe dry eye was more frequent in diabetes, affecting 50% of patients, whereas only 10% had a similar severity. Corneal sensitivity using the Coque-Bonnet aesthesiometer revealed that the absence of dry eye was more common in non-diabetic, that is 70%, than in diabetics. And the sensitivity showed a marked reduction in diabetes with a mean reading of 45.2 plus minus 3.1. Association of DED severity with diabetic retinopathy was 50% among NPDR and PDR, showing moderate to severe dry eye disease association with diabetic retinopathy. Schirmer's test values demonstrated significant reduced tear production in diabetics, reflecting impaired aqueous tear secretion in the diabetic age group. T-Butt suggested greater tear film instability among diabetic patients. Distribution of the symptoms was done according to a questionnaire based on foreign body sensation, burning, itching, blurred vision, and excessive watering. And the diabetic group experienced more of these dry eye symptoms. Conclusion. In this study, we found that diabetic patients had a significantly higher prevalence and severity of dry eye, with 50% of diabetics showing moderate to severe disease, along with reduced corneal sensitivity. These are consistent with the results of Manaviet et al., who reported that the prevalence in type 2 diabetes was significantly higher in controls and associated with the presence of retinopathy. Similarly, Dogru et al. Observed impaired tear function and ocular surface abnormalities in diabetes, highlighting the role of chronic hyperglycemia in altering the tear film stability. Kosen et al. Reported that diabetic patient had reduced corneal sensitivity compared to non-diabetic, and this worsened with increased disease duration. we observed a positive correlation between HbA1c and DED severity with the study of Big Bova et al. These findings highlight the importance of routine screening for dry eye and corneal nerve changes in diabetic patients, particularly those with advanced retinopathy, as early detection and management may prevent the ocular surface complications and improve overall quality of vision. These are my references. Thank you.
So we have three parameters: diabetes, tear film stability, and corneal sensitivity.
Yes, sir.
So in what way tear films stability affects this corneal sensitivity? Diabetics affect the corneal sensitivity. Tear films and corneal sensitivity, what is the correlation?
So in diabetics, due to dry eye, there are the trophic factors which are not reduced, and there is loss of tear film homeostasis. So this causes more dry eyes in diabetes, and there is also reduce in tear breakup time, so causing dry.
Why the patient with pilocarpine not included? Patient's own pilocarpine not included in this
Not
study.
included, sir.
So any specific reason?
So as a side effect, it can cause dry eye as a side effect, sir.
So you measured corneal sensitivity with SST?
Yes, sir.
Yes,
Yes.
this is. ठीक है.
Thank you, sir.
Next speaker, Dr. Ishita Modgil.
So shall I start?
Yes.
Very good afternoon, respected chairpersons, judges, and my dear colleagues. I am Ishita, Department of Ophthalmology, second year PG resident from the MGM Medical College, Kishanganj, Bihar. I will presenting my study title, Correlation of Infrared Autorefractometer Based Meibography with the Clinical Signs of
Timer is
Meibomian
not
gland.
going. Timer. पहले
Let's have the brief introduction. Meibomian gland dysfunction is the leading cause of evaporative dry eye disease that affects 20 to 60% of adults worldwide and significantly reducing the quality of life. Recently, infrared autorefractometers with integrated meibography modules have made gland imaging feasible during routine refractive examinations. This allows rapid, non-invasive, opportunistic screening from the MGD. Establishing this relationship could support the use of refractometers as a practical screening tool, enable early detection and intervention, reduce the reliance on subjective grading. Aim of my study is to correlate the infrared autorefractometer based meibography with the clinical signs for detecting MGD. And objective is to analyze the demographic and clinical correlates in patients of MGD such as age, gender, and grading of the meibomian gland dysfunction with the help of autorefractometers. This is the standardized terminology and frequency data for the meibomian gland dysfunction in population, and epidemiology showing these are specialized sebaceous glands that produce meibum essential for the tear film stability and protection and prevention of the evaporation. These are my slit lamp photographs of meibomian orifice plugging of abnormal meibum, which is opaque, viscous, and diffuse, difficult to express, and slit lamp photograph of the eyelid margins, foaminess. My study was an observational hospital-based study. I have recruited 137 patients. The tools I have used: Stenel's visual chart, slit lamp, and infrared autorefractometer. I have included the patients diagnosed with clinical signs and symptoms of MGD, patients above 18 years of age, patients giving informed consent to participate in the study, and excluded patients below 18 years of age having the presence of active ocular infections, that is conjunctivitis and keratitis. Patients have underwent recent ocular surgeries and procedures in the last 6 months. Systemic conditions affecting ocular health known to affect the meibomian gland dysfunction. Regular contact lens wearers, especially those who have worn lenses within the last 1 month. Patient with severe allergy and unlikely to comply with the study procedures or follow-up visits. By this formula, I have found 137 patients, and the 3 patients was not included due to the incomplete data. Now comes to results and analysis. The first one is age distribution of study participants. This showing mean age is 33.5 plus minus 8 years. Secondly, sex distribution of study participants showing clear female predominance. Then the symptoms, distribution of presenting symptoms showing most commonly presenting symptom is foreign body sensation, burning sensation and dryness. Next is meibography findings. The most common grade of gland dropout comes to the grade 1. Correlation of clinical signs with meibography is plugging of orifices, altered meibum quality and reduced expressibility show a good correlation, unlike lid margin telangiectasia. Agreement between the clinical diagnosis and meibography shows substantial statistical value as the kappa value comes out to be less than 1, that is 0.78. Discussion. So all these findings support Lawrence, Quintana et al., who emphasize that infrared meibography is a sensitive non-invasive tool allowing earlier detection. Similarly, Bonava et al. In 2023 validated a handheld infrared meibographer with automated gland quantification. Clinically altered meibum quality was the most common sign, followed by plugging and reduced expressibility. This aligns with Deng et al. In 2024, who identified meibum quality and expressibility as a strong predictor of lipid layer thickness and tear film stability. Together, all these findings underscore the value of integrated meibography with functional assessment to improve the diagnostic confidence and facilitate timely intervention in MGD. To conclude, the majority of patients were young to middle-aged patients with female predominance. Most common presenting symptoms were foreign body sensation, dryness, burning sensation. Altered meibum quality and plugging of gland orifice emerged as the most frequent clinical signs and showed significant correlation with meibography findings. Meibography detected gland dropout in nearly 4/5 of eyes, with grade 1 and 3 being the most common patterns. The agreement between the clinical diagnosis and meibography was substantial. As I told earlier, the kappa value comes out to be less than 1, that is 0.78. These results reinforce the value of meibography not only in confirming the clinical diagnosis but also in grading the severity more precisely. Thus, meibography using an infrared autorefractometer should be considered a useful adjunct in routine ophthalmic practices, as it improves diagnostic confidence, helps stratify disease severity, and can aid in monitoring progression or response to therapy. These are my key references. Thank you.
What infrared meibography you are using? What autorefractor?
Which machine?
Infrared.
Which company?
How do you measure the loss of meibomian glands? And photograph analysis?
Yes, sir. We put the upper eyelid and patients with symptoms the infrared autorefractometer and with the help of infrared light, easily see
You are using any separate button for infrared or already infrared is there?
You have correlated with the T-but?
Yes, sir. I'm not included in the study because it's all based on the infrared autorefractometer, but I have used.
How many cases you did?
I have used 137 patients I have used.
One. Okay. So it is convenient.
Yes, sir, this is convenient, sir. If the patients are willing to sit on the infrared autorefractometer, then we can easily invert the upper eyelid and see the toxicity of the meibomian glands.
Dropouts can be made. Okay. Right. Next speaker, Dr. Vishal Prakash. Dr. Vishal Prakash Nandeshwar, please.
Good afternoon everyone. My topic is tacrolimus and the combined use of tacrolimus with olopatadine in VKC comparative prospective study. Allergic eye disease is a common ocular condition that we encounter in our clinical practice. Vernal keratoconjunctivitis is a recurrent bilateral interstitial self-limiting allergic inflammation of the conjunctiva having a periodic seasonal incidence which subsequently affects the cornea. The topical use of antihistamines, mast cell stabilizers, and more recently the combined effect of both, termed as dual action drugs, represent the first line treatment for VKC. In more severe forms, corticosteroids are used for short term to induce the remission of the allergic crisis. Tacrolimus, a macrolide bacterium Streptomyces tuberculosis derived, is a potent immunomodulator capable of decreasing the production of inflammatory mediators by T lymphocytes through the inhibition of calcineurin and intracytoplasmic protein essential for interleukin 2 and 4 transcription. This study is focused on comparing the efficacy of tacrolimus versus tacrolimus with olopatadine as therapy in VKC. My aim of the study is to determine the efficacy of topical 0.03% tacrolimus as a single versus its combination with 0.1% olopatadine VKC. It's a comparative prospective study. The sample size 50 patients were taken and were divided into two groups, group 1 and 2. The study center was Department of Ophthalmology and IGH, Rourkela, and it was conducted over a period of 3 months. Inclusion criteria: all VKC patients refractory to conventional therapy coming to the OPD of IGH. Refractory in this context meant that the clinical condition was maintained or worsened during the use of topical corticosteroids and there was a relapse after withdrawal. Exclusion criteria: patients are on antihypertensive, antihistamines, antitussives, antiandrogen, contact lens wearers, previous history of ocular surgeries, history of autoimmune disorders, and those who have not given any consent. So the patients randomly were divided into two groups, subgroups A and B, each group containing 25 patients each. Both the groups were given 0.03% tacrolimus ointment which was applied twice daily. Group A was given tear drops as placebo along with the ointment, and group B was given 0.1% olopatadine along with the ointment. Both the eye drops had similar flasks, so with no identification which was given to the patients along with the ointment. For double masking, the eye drops were numbered and contained no identification of the drug. The content of the flask was revealed only at the end of the data collection period. The randomization was performed using a block system, and all the symptoms and signs were graded at 0 on a scale from 0 to 3 on day of presentation, after 30 days and after 90 days. To assess the safety and side effects of the treatment, itching, opacification, burning, intraocular pressure, lens, secondary infections or other possible complications were also assessed. The student's t-test for independent sample was used. To compare the results for the two assessment times within each group, the student t-test for paired samples was used. When comparing the two groups regarding the qualitative variable, Fisher exact test and chi-square test were used. P-values less than 0.05 were considered significant. This is how we graded in 0, 1, 2, 3 for the symptoms and the signs. Coming to the results, in the study group of the age group of the patients, majority were found to be from 6 years to 15 years, out of which 82% were male and followed by 18% female, and 82% were school going children followed by preschool children and followed by children working outdoors with their parents. 80% of patients were from rural area. Majority of the patients were of bulbar variety, 46% of VKC followed by palpebral 34% and mixed 20%. Total 11 out of 50 patients, that is 22%, were presented with corneal involvement, out of which 13.04 were of bulbar form, 4 out of 17, 23.52% were palpebral form and 4 out of 10 were of mixed form, shows the corneal involvement. SPKs were present in 7 cases, epithelial scarring in 4, and corneal involvement was observed more among patients having palpebral or mixed type of diseases. So these are the graphs which show the conjunctival hyperemia on day 0, 30 and 90, and followed by tarsal papillary reaction, punctate epithelial keratitis and limbal gelatinous infiltrate. This is the itching score over time. This is the tearing score, foreign body sensation score over time, photophobia score over time, discharge score over time, and this is a combined graph which shows the signs and symptoms were found to be reduced at day 90. So refractory VKC is a difficult condition to treat. Steroids relieve the signs and symptoms, but long-term use is known to cause serious side effects. So in this study, we compare the isolated tacrolimus with combined use of tacrolimus and olopatadine. The majority of the VKC were found to be at 5 to 25 years old of age, with age of onset between 10 to 12 years of old. Sacheti et al. Discovered that VKC patients with corneal involvement or more than one recurrence per year had an increased risk of permanent visual loss. In present study, 11 out of 50, 22% were with corneal involvement. To conclude, the isolated use of tacrolimus and the combined use of tacrolimus with olopatadine have similar efficacy in reducing the clinical symptoms and signs in cases of VKC, which are refractory to conventional therapy. These are the limitations of my study and my references. Thank you.
So in one group you have used tacrolimus and in another tacro with olopatadine.
Olopatadine.
So any study with only olopatadine?
Only olopatadine, no, sir.
Can we compare only olopatadine twice or tacrolimus by time?
So we were trying to treat for the refractive cases. So we have included tacrolimus as the main.
All are refractory cases.
Refractory cases.
After using steroids and all.
Yes, after using steroids, those who have not, the condition has not relieved or it was maintained, and while when we were weaning off the steroid, the patient was again relapsing.
Yes.
For those patients, we have tried tacrolimus.
I think your study correlates well with all other studies.
Thank you, sir.
Okay. Next speaker, Dr. Tahira Aziz.
Good afternoon, everyone. Myself, Tahir Aziz, junior resident in the Department of Ophthalmology, AMU Aligarh. Today I am going to present my study titled Conjunctival Impression Cytology in Patients with Dry Eye Disease and Low Vitamin D Levels, a hospital-based observational study. Vitamin D has been demonstrated to have anti-inflammatory and immunoregulatory effects in several studies. It has been found that vitamin D receptors in the corneal epithelium, as well as the role of vitamin D in maintaining corneal epithelial barrier function, and some transporters like megalin, cubilin in tear-producing glands, which suggests that it has a significant role in ocular surface homeostasis. The conjunctival impression cytology is the process of removing 1 to 3 surface epithelial cell layers while maintaining the original morphology. It is comparatively simple to perform, minimally invasive, and causes the patient least amount of discomfort by providing accurate information about the area sampled. Our purpose of the study is to evaluate the CIC findings in patients with dry eye disease having low vitamin D levels, with an aim to study the potential role of vitamin D in maintaining conjunctival epithelial integrity. It is an observational cross-sectional study conducted at our institute for 1 year. Consecutive sampling of eligible patients were done, and sampling units were taken as clinically diagnosed dry eye disease patients. Sample size was 40 and assessment was done based on dry eye disease diagnosis, Schirmer's 1 and 2, Tibet, Osdi questionnaire. Vitamin D status with less than 20 nanogram per ml was taken, and cytology, CIC was formed from temporal bulbal conjunctiva, stained with PAS and HNE, and graded by Nelson's classification. The inclusion criteria was patient aged more than 18 years, clinically diagnosed with dry eye disease, serum levels of vitamin D less than 20 nanogram per ml, and who gave informed consent. Our exclusion criteria was any prior ocular surface disorder other than DED, history of ocular trauma or surgery, use of medications affecting tear film, diagnosed systemic diseases like diabetes, mellitus, hypertension, and patient unwilling to participate. These are the baseline socio-demographic characteristics of the study participants, with the maximum patients belonging to age group 18 to 30. Mean age was 35.1 plus minus 13.9 years. Mostly were males residing in the urban population, and patient belonged to college and above group, and the occupation mostly were unemployed, which included students as well. The results included the mean vitamin D levels in males to be 12.4, in females as 11.2, and overall it was found to be 11.8 nanogram per ml. These are the figures showing distribution of study participants according to CIC grade. Most of the patients had grade 2 and lesser patients had grade 1, and in our study, which was of 40 participants, none had 0 and 3 grades. The correlation of vitamin D levels with CIC grade was done, and based on it, it was found as negative correlation was found as minus 0.445, and it was found to be significant, the p-value. These are the photographs of the CIC slides that we made. The first figure shows the Nelson's grade 1 showing sheets of epithelial cells with NC ratio of 1:3. This is an HNE at 40x magnification. The next slide we can see sample from the same patient on PAS stain with arrows showing the goblet cells. In the next figure we can see Nelson's grade 1 showing good cellularity of epithelial cells in sheets, HNE at 4x magnification. And the other slides, the next one shows the grade 1 showing epithelial cells having ratio of NS to C ratio 1:2, and the arrows showing the goblet cells, HNE at 40x magnification. This is the grade 2 showing goblet cells on PAS stain at 40x magnification, and the next figure shows epithelial cells with squamous appearance and NS to C ratio of 1:3, and it is PAS stain at 40x magnification. So our study concluded that vitamin D deficiency is associated with abnormal conjunctival impression cytology in patients with dry eye disease. A considerable proportion of patients exhibited squamous metaplasia, goblet cell loss, and higher Nelson's grade, predominantly grade 2 in our study, indicating impaired epithelial homeostasis. The changes seen correlated inversely with serum vitamin D levels, suggesting that lower system vitamin D is linked to more severe ocular surface pathology. Our results suggest that vitamin D deficiency may not only be a systemic risk factor but also a potential modifiable contributor to ocular surface disease. Correction of hypovitaminosis D could therefore play a supportive role in improving epithelial health, reducing squamous metaplasia, and enhancing goblet cell density in dry eye disease patients. Thank you.
So would you like to suggest vitamin D to?
Yes, according to our findings in these 40 patients, we saw that the vitamin D levels, the low serum vitamin D levels, they were associated with metaplastic changes in the cells like increased NC ratio, and so it is an ongoing study. We are enrolling more patients.
What is duration of study?
Yes, sir.
Time duration of study.
It is 1 year. It has been just 1 year, and we have 40 participants enrolled.
Have you seen any changes in symptomatology after giving vitamin D or
yes,
this part?
Yes, sir. I have seen. I have after 8 weeks of intervention. Although the grade of Nelson's grade not much improvement, but the cytological changes have been seen, and they have been noted also. Thank you.
Is Dr. Brinda Periasamy is it? Yes, please. Keynote speaker.
Good afternoon all, I am Dr. Brinda. I like to thank AIOA Scientific Committee for selecting my work as the best paper of the external IDC session which happened last year AIOA's midterm conference. And I like to thank my mentors Dr. Geeta Behra and Dr. Ramesh Babu sir. I'll be addressing my paper on evaluation of dry eye in rheumatoid arthritis and systemic lupus erythematosus and its association with anti-SSA and SSB autoantibodies. Dry eye is a multifactorial disease and the ocular surface is maintained by the tight immune regulation which fights exogenous and endogenous pathogens while maintaining tolerance to the self-antigens. In autoimmune diseases like SLE and RA, this regulation is broken by the multiple triggers which results in aberrant activation of the immune system. As we already know, anti-SSA, SSB autoantibodies are associated with the primary Sjogren syndrome, dry eye. In secondary Sjogren syndrome in SLE and RA, the proposed pathology is impaired tear production because of the lymphocytic infiltration by the self-reactive immune T cells. My study aim was to estimate the prevalence and association of the dry eye with anti-SSA, SSB autoantibodies in the rheumatoid arthritis and SLE patients. We included patients above 18 years of age with rheumatoid arthritis according to ACR-Euler 2010 criteria or systemic lupus erythematosus according to ACR-SLIC 2012 criteria. We included 90 rheumatoid arthritis patients and 55 SLE patients and excluded patients with active keratitis, conjunctivitis, Stevens-Johnson syndrome, cicatricial pemphigoid, lacrimal gland malignancies and sarcoidosis. In the methodology, we documented the duration of the disease. Disease activity was calculated using DAS-28 for rheumatoid arthritis and SLE disease activity index for SLE patients. Self-reported dry eye symptoms were noted, topical and systemic medications were noted, and anterior posterior segment examination was done. All patients were subjected to dry eye questionnaire of both OSDA and SPEED and objective dry eye test, which included the Schimmer's test, ocular surface staining, where we done both SICA OSS staining and National Eye Institute staining score. Tear breakup time with fluorescein was done, and all patients were subjected to serology for ELISA of the anti-SSA-SSB autoantibodies. Coming to the results, in the rheumatoid arthritis group, the mean age was 44 years, and in the SLE, it was a decade younger, 32 years. And in both groups, the female predominance was noted, and mean duration of disease was 6 years in rheumatoid arthritis and 7 years in SLE. In both the groups, the majority of the population were in remission or low disease activity. Self-reported symptoms was noted in 35% of RA patients. With the questionnaire, SPEED was able to detect more dry eye, which was 57.8%. So SPEED scores were more than the OSDA. This discrepancy was because some of the questions in OSDA were not applicable to the Indian setting. The similar pattern was noted in the SLE. The SPEED questionnaire was more effective. And when comparing between RA and SLE, RA patients were more symptomatic than SLE. Coming to the dry eye prevalence, in both the groups, the tear film quality was affected more than the quantity, indicating that the subclinical dry eye disease is more prevalent than the symptomatic dry eye. Even though 35% of RA and 25% of SLE patients were symptomatic, less than 5% were previously diagnosed with dry eye and were on treatment. This highlights the need for vigilant screening of dry eye, irrespective of the symptoms, disease activity and duration. And the relation of the disease duration and activity, there was no significant association with the disease duration because the patients were already on treatment as the median duration was 6 years. And coming to the disease activity, the majority were in the remission or low disease activity. Even though they were in the remission phase, their tear film quality was affected. They had abnormal TBUT and staining scores. This suggests a subclinical dry eye disease in the minimal disease activity. The similar pattern was noted in the SLE group also. Apart from the tear film quality and quantity, the anti-double-stranded DNA discoid lesions of the lid and methotrexate resulted in blepharitis, and immune complex deposition causes the meibomian gland dysfunction. So the lid examination is also as important as the tear film assessment. Coming to the anti-SSA-SSB autoantibodies, in rheumatoid arthritis group, we were able to had a low detection of the autoantibody level, and they had no association with the dry eye. In the SLE group, 31% were positive for SSA antibodies, of which majority of them had a poor tear film quality. Coming to the discussion, among the patients of RA and SLE, the abnormal staining scores and tear film breakup time scores were comparatively higher to the abnormal shimmer scores. This indicates that the ocular surface inflammation is the major pathology than the decreased tear production, and there is no significant association with the SSA-SSB autoantibodies. So the anatomical target is ocular surface epithelium more than the lacrimal gland, the suggested pathology being increased pro-inflammatory cytokines at the level of ocular surface. So secondary Sjogren's syndrome with a decreased tear production causing dry eye could be a minor mechanism in the rheumatoid arthritis and SLE patients. The postulated dry eye pathways could be multiple risk factors causing autoreactive T cells or impaired neutrophil extracellular trap formation clearance or increased cytokine production by the activated Langerhans corneal cells, all of which causing the local ocular surface inflammation resulting in dry eye. The strength of my study was, it is the first study to report dry eye in both SLE and RA Indian patients, and this is the first study to utilize two subjective dry eye questionnaires, OSDA and SPEED, and demonstrating SPEED has a greater applicability in our Indian setting. And the limitation was we did not look for tear film hyperosmolarity, and in our study the majority of them were in remission or low disease activity. Only few patients were having severe disease, so we were not able to comment accurately on the association with the dry eye. So dry eye in SLE and RA has no association with the SSA-SSB autoantibodies, disease duration and activity. Subclinical dry eye is more prevalent, and the recommendations are vigilant screening is required, and the order of assessment should be symptom assessment with the SPEED questionnaire even if the patient is asymptomatic, and tear film quality assessment with the staining and fluorescein tear film breakup time, which is imperative, and tear film quantity should be the third, and last but not the least, lid examination should be important. These are my references, and thank you.
Thank you all. Well done, very well done. But one thing is, your generation is now more of a DED, more of a myopia, more of a diabetic retinopathy than cataract and glaucoma. So you have to concentrate more on dry eye diseases. Yeah. All of you, well done. And I think they will announce the results later. Thank you.